Good day. I'm Vanessa Pazernik, Senior Biostatistician in the Department of Research Support at A.T. Still University. Today's presentation will discuss research methods. This module is split into two parts. This is part one. The goal of this module is to understand how to transform your research question into valid research methods. Your research question was developed using that PICO framework. Specifically, you will be required to understand basics of study design, understand development of valid research methods, and understand good time management. We'll also be looking in depth at several example studies and their research methods. So before we get into the basics of study design, I want to give context using levels of evidence. So when you become a clinical practitioner and give your patients the best outcomes, you're doing that using the integration of best research evidence with clinical expertise and patient values. To find the best research evidence, this guide ranks studies based on their ability to control for bias and demonstrate cause and effect in humans. So at the top are studies that appraise the quality of studies and often make recommendations for practice. Primary studies collect original data. So randomized controlled trials are generally considered the gold standard for clinical research and are typically used to answer questions related to therapy or interventions. Observational studies are a step below, typically used to answer questions regarding diagnosis, etiology, or prognosis. Since most MOSDOH D3 research studies have been observational studies, I will talk more about observational studies in the next few slides. And below these are studies with lower tiered evidence. This is a tree of primary studies. This splits into two subgroups by descriptive or analytic, and whether the analytic studies are experimental or observational. Descriptive studies try to give us a picture of what is happening in the population and doesn't try to quantify a relationship. An analytic study tries to quantify the effect of an intervention or exposure on an outcome, and the PICO framework applied to these studies. An experimental design differs from an observational study when the intervention is controlled by the researcher. Some projects have used experimental designs where we administer a pre-survey, then do some sort of educational intervention, and follow up with a post-survey. These are non-randomized if we don't have a control group where everyone gets the same intervention. Most studies for the MOSDOH D3 research projects have been observational. An observational study can be one of three basic study designs based on when the outcomes were determined. In a cohort study, the outcome comes sometime after the exposure. The cohort study can be either called prospective or retrospective, depending on if the cohort is being followed for future outcomes or if the outcome has already been observed. One example is Dr. Susan Adams' project assessing the completion rate of definitive restoration following endodontic treatment for the underserved. This is a cohort study where the group of people were the underserved patients seeking care at her clinic with root canal therapy, and the outcome was completion of follow-up treatment. In a cross-sectional study, the exposure and outcome are measured at the same time. It's unknown if exposure precedes outcome. One example of this is Dr. Michael Abel's project on measuring the mental health effects of dental school students and social support. We looked at relationships between their total stress score and agreements with various statements regarding having good mentors and support systems. In a case control study, we find cases of patients with the outcome and controls for patients without the outcome and look back for exposure. One example of this is a study assessing the relationship between current gingival health in college students and having professional oral hygiene instructions during childhood. We can take all college students with poor gingival health and ask them whether they received oral hygiene instructions as a child, and repeat the procedure on a set of suitable college students who do not have poor gingival health. Then compare the rates of oral hygiene instructions between the two groups. This has traditionally been viewed as an inferior alternative to the cohort study, but recently in the last 30 years or so, it's been viewed as an efficient way to learn about the relationship between an exposure and disease, especially if the outcome is rare or has a delayed onset. One note is to reserve retrospective and prospective adjectives to cohort studies only. These terms convey timing of exposure and outcome measurement. So remember, the cohort study can be called either prospective or retrospective, depending on if the cohort is being followed for future outcomes or if the outcome has already been observed. I recommend refraining from using these terms to describe cross-sectional and case control study designs, as these already convey the timing of exposure and outcome measurement. I included this slide to bring awareness that the literature is not consistent. For example, you may see something called a prospective cross-sectional study design, where the authors attempt to describe the timing of a study conduct as prospective and timing of the measurement as cross-sectional. Some papers use the term retrospective to define existing data, which in medicine it does mean. For example, some studies which use a cross-sectional design on existing data are called retrospective cohort studies. For more information, one book I do recommend is The Essentials of Epidemiology and Public Health, which is available on the ATSU library webpage. Now that we've covered some basic study designs, let's talk about the rest of the methods. The methods provide the information by which a study's validity is judged. Therefore, it requires a clear and precise description of what was done and the rationale for why specific procedures were chosen. For the methods, you need to be precise on what you're going to do. Think of this as a recipe for your study so others can understand how they could replicate it. There are 5 major sections to the methods. The first is the study design. So which study design are you going to use? Typically, it will be one of the 3 analytic observational designs. For the materials, are there any special materials to collect data, such as special dental equipment or data collection tools, such as Qualtrics? You need to explain how they are prepared and who will prepare them. For the study sample, explain the eligibility criteria. This will include information on certain demographics and health histories possibly, as well as diagnostic criteria if applicable. For example, if poor gingival health is your outcome, what is your diagnostic criteria? You should also include how many samples you will collect. For the data collection, you may be using existing data or collecting new data. Either way, data collection needs to have a time frame. How many years back are you looking? How many months are you actively collecting new data? Figure out all your variables. These include outcomes, predictors, and confounders, and the measurement detail. You can measure health a lot of different ways, so make sure your variables are well defined and also that your statistician understands these as well. Make sure you know how and who will be doing all of this. For the statistical methods, describe the statistical analyses, including any statistical tests. These will typically be assisted by your statistician. The methods also need to have a rationale for why specific procedures were chosen. The overarching theme here should be the methods were chosen because they best answer our research question. For the study design, the reason may be based primarily on efficiency or ethical considerations. There may be only one that works. Also, studies using existing data are easier because new data collection is not needed. However, you have limited control on problems with the data, such as being incomplete, inaccurate, or inconsistently measured between subjects. The materials chosen can be justified if they've been validated or viewed as valid by the dental community. For example, for the mental health of dental students, we found a survey instrument designed and validated to measure stress, then modified it by adapting to dental students and limited the total number of questions to reduce survey fatigue. A dental procedure may only have one accepted method, so if that's the case, that's your rationale for using it. For the study sample, eligibility is based on who you want and do not want to study. If you have any specific exclusion criteria, you should justify them. In general, your sample size will depend on what is feasible and, if applicable, on power analyses, which a statistician can assist with. For the data collection, overall, choose the method that minimizes errors and biases as much as possible. Train all data entry members so data collection is consistent. One good example exhibiting consistency was on Dr. Crivello's urgent care project, where we used Google Sheets so he had easy access to view the students' progress in entering data. We also had a pilot round and training of all members prior to live data collection. A lessons learned from past students was to always enter study data right after the patient visit while it's fresh in your mind rather than wait, which improves accuracy. If there are subjective ratings that need to be collected, consider having either a single rater or use a combination of blinding and consensus training to increase agreement. The statistical method should answer the research question and take into account assumptions of statistical tests. These should also justify using any confounding variables and statistical models. For example, we might want to adjust for eating habits if we want to estimate the relative risk of caries in brushers versus non-brushers. The biggest error I found is when we analyze data collected at the tooth level but don't account for the lack of independence between teeth in the same mouth. For example, research shows that caries teeth in the same individual are more highly clustered than caries in different individuals. This makes sense because teeth in the same mouth are exposed to the same environment, including diet and oral hygiene habits. If we ignore this lack of independence, it can bias our estimates. As a statistician, I need to understand exactly how you collected data so I can properly account for different sources of variability. On one project, I redid much of the analyses after realizing several instances where multiple teeth were supplied by the same individual, which did affect our previous analyses. For more information on what you should be including in your methods, the STROBE guideline is an excellent resource. See the Ecuador Network for this and other well-known reporting guidelines as well. After you've created your methods, you need to develop time management. Create a timeline that includes actions and persons responsible. Previous research teams stressed the importance of deadlines. Performing research takes time, so break it up into manageable pieces. Schedule regular research team meetings to keep on task. This concludes the Research Methods Module Part 1, developed by the Department of Research Support for A.T. Still University's Missouri School of Dentistry and Oral Health. Have a nice day.